you a way of thinking about proximal humeral fractures. I thought certainly the case. Oh, that's really badly projected. Yeah. So this was a 77-year-old lady who fell in Portugal. She was fit well, in that she could get herself to Portugal, get herself back again, and she moved on some antihypertensives. But she came back with this injury. She came with a sling. She escaped an operation. So I want you to have a look at this. I'm just going to give you a minute. Have a think about what you think the diagnosis is.
I mean, it doesn't project well enough to. Maybe it's just me.
We'll move on. So I'll describe what it is. Basically, she's got at least a 4-part fracture, and that this. Let's see if this works. Hold on a second. So this bit here, that's her head. That's the actual head that's sticking out the back. Okay, it's like match of the day, isn't it? Except not. Okay, right. All right. So the head's facing out the back. So she's got a 4-part fracture dislocation. So have a think about, if you saw this in clinic, what would be the things that would influence what you would do with her? Whether or not you'd offer an operation, what would be the indications for an operation, what operation would you offer her? That's basically the question. The X-rays are kind of ancillary. So 4-part posterior fracture dislocation, how are you going to approach this patient? Just have a think about what the things are that are going to affect your management. You can also think whether it's important that she has a disposable income and she can afford to go to Portugal. That might have bearing for some people who work at 7. Okay, so this is a 53-year-old bloke who's a forklift driver. Fell on ice, he's got hypertension, he's got COPD, and he's got this isolated proximal humeral fracture. These were his X-rays when he first presented to ED, and when he got seen in clinic for the first time, that's his X-ray there. And again, I'm sorry, it doesn't project very well, but basically you've got probably at least a 2-part fracture, and the head's gone down to varus, and there's not a huge amount of bone stock. So again, have a think about what the implications in this individual, 53-year-old, some medical comorbidities, works doing a manual job, how you approach this chap. So again, I'm going to give you a minute just to have a think about that. Have a think about what you would be offering him. Okay, hopefully that's giving you some food for thought. So that's kind of that MCQ question, wasn't it? So the key elements of the proximal humerus, one of the key factors is the vascular anatomy of it, and the potential disruption of that vascular anatomy. Because avascular necrosis is a particular risk in proximal humeral fractures. And effectively, you could think about whether the fracture is an intra or extracapsular fracture in very much the same way you do in a femoral neck. And I'll talk to you about some of the evidence behind it. I'll explain that comment in a second. The second thing is you've got to be able to interpret the X-rays for these. So the way that these fractures behave is pretty predictable. The parts are predictable. And the reason that parts occur in any fracture, and this will be covered this term as well, is usually because there's something attached to that chunk of bone that gets pulled off. Okay? So the reason why we think about 1, 2, 3, and 4-part fractures, we'll never think about 1-part fracture because that's not a fracture, I guess a hairline. But basically, the reason we think about 2, 3, and 4-part fractures is because the fractures patterns happen in a reproducible way, and they all relate to where the cuff inserts. So you may get one part which is the shaft, and if you hear me talking to patients, I talk about it being the ice cream cone. And then you actually get the head itself, which is like the ice cream sitting on top of the cone. Okay? And you get the less tuberosity at the front, and you get the greater tuberosity at the back. And when they fall, those fragments, if they've got a patent cuff, then they will pull those pieces of bone off, okay, to varying degrees. And those are the deforming forces. So you get those fracture fragments happening, and they will displace in the direction of pull. And there's 2 important muscles that have been missed off this illustration, which are also lat dorsi and pec, because that's what medializes the shaft. So if you understand the deforming forces, that also helps you think about what you're going to need to potentially release or relax or pull against when you do reductions. But the patterns themselves are pretty predictable. Look, like in the elbow, we talked about the way in which the condyles tend to face towards each other because of the common extensor origin, complex origin. Same thing in the shoulder, in that the pull of the muscles affects which way they go. And once you start to recognise the patterns, you can interpret a lot more from the X-ray. Classification. NIRS classifications kind of stood the test of time, talking about the parts, and those are the different parts. But the true classification was according to how displaced it was. So it should be more than a centimetre displacement and more than 45 degrees angulation. Now, in real terms, we often talk about ones that are less displaced than that. I mean, if we think about a GT fracture, and we worry about whether it's 5 mils displaced or 10 mils displaced, we still think of it as a displaced fracture of pieces off and you can see it. But NIRS' classic description was this. Okay. So how does that kind of translate into the kind of real world? So we talk about anatomical and surgical neck, okay, being different, and then you get these kind of 3-part fractures going on to 4-part fractures. And that's kind of the constellation of injuries that we tend to see. There are things that can make your diagnosis easier, and this is again a potential MCQ question. So the kind of classic scapular AP, does anyone know what the American name for that is? You'll see it in the American MCQs. Grashey view. Yeah, okay, so you've had serendipity view, Grashey view. Americans love putting their names to this stuff. So a true unihumeral AP is really important. So in my trust, we get, well, for the first couple of years I worked there, we used to just get an AP of the chest centered on the shoulder, and it was non-diagnostic, you couldn't tell anything from it. And when someone's got a sling, you end up with an internally rotated humerus, and then this direct AP view, and you end up thinking they've got a posterior dislocation. That's pretty much what it looks like, because you're not seeing the unihumeral joint perfectly and true, whereas you actually want to take this kind of 30-degree view to get a proper diagnostic quality view. And if you get those, often you can get most of the information you need from the X-ray. CT now is increasingly being used, but it's not mandated in the initial assessment. It's usually just helpful if you actually get on and do a recon from it. And this was just a paper describing the 3D anatomy as based on CTs, but CTs are increasingly being used more and more for these. And this is an example of this. So this was a patient who had, I think it's at least a 3-part fracture. I think it's a 4-part component to it. Yeah, there is. But the 3D recons can be quite useful if your radiographers aren't particularly up on getting you the perfect reconstructions. Having a 3D view that you can spin can give you really useful information, particularly when you're starting to get your head around these injuries too. So I recommend using these. Okay. So, anyone know what classification that is? This is an advert for the Lego 2 movie.
Hertel.
Yeah, Hertel and Vigiani basically came up with this this Lego brick classification. So there are 12 different iterations of the fractures. You don't need to know this. This is what's used in research. But the reason for putting this up here is really just to show you what a diversity of different fractures there are. And that's probably why there is so much equipoise in the literature, is because it's very difficult to compare similar groups of fractures with each other. So there's 12 different potential iterations. And this one, the predictors of humeral head ischemia, is really what I'm going to talk about next, because that's just some of the ways you can conceptualize whether you've got something that's got a high risk of AVN, low risk of AVN or not. And finally, the axillary nerve. That's the commonest injured nerve with proximal humeral fractures, and you have to examine for it when you're assessing these patients. And you'll often see people who have a sensate axillary nerve and will have some contracting, some palpable deltoid contraction. You can feel it if you ask them to push against your hand. But when you look at the X-ray, you'll see this inferior sublux humeral head. You all seen that? And the question is, well, why have they got that? Have they got an impaired axillary nerve, but yet they can feel it? And I haven't read an answer for that, but I think it's a similar thing that you see with knee injuries. You know, when you see young women with knee injuries, particularly, they get quads inhibition. And I think you get deltoid inhibition in the shoulder, and it can take up to a month or 2 to settle down. So you get someone who has this horrible looking inferior sublux joint. The fracture morphology is not bad. And then over the next few weeks, you just support them with a sling. They forget the pain when it's inferior subluxing. you support them, and then over the next kind of couple of weeks, they gradually come back up into a normal position. But I don't know, Pete, you're now at the tail end of upper limb. I mean, have you seen any explanation of why that happens?
No, I've heard you say that.
Yeah, I've said that. It's
And hemarthrosis as well.
Yeah, hemarthrosis. So some displacement from hemarthrosis too. Yeah, I mean, I think that's reasonable. Anyway, so don't forget to examine the axillary nerve. It's an important component of it. And it will help, if you've got somebody you're going to operate on, knowing what the axillary nerve function is important, because you need to document whether you've damaged it or not during your operation. And also it's going to affect your choices about what you do potentially. So this is what Hurtel's paper about vascularity was about. And effectively, what it said was, if your calcar fragment, in other words, the little lip of bone on the bottom of the articular fragment, is 8 millimeters or longer, then the blood supply tends to be preserved. So the way that I rationalise this is think of it like an extracapsular fracture in the hip. Yeah? So when the fracture extends into involving the trochanters, you're going to put a DHS in, you're less worried about AVN. Whereas when it's an intracapsular fracture, you're worried about the AVN wrist. So this is the equivalent of that in the shoulder. Does that feel like a crowbar plot move, or does that make some sense to you? I can never remember whether it was going to be 8 mils or less than 8 mils or more than 8 mils, and I thought, what's that bloody hit? Okay, so in other words, long fragment, that's good, it's extracapsular. Small fragment, it's an intracapsular, it's more likely to affect the blood supply. That's how I rationalise it. The second thing is the medial hinge. So, have you got a long calcar fragment, and is the calcar itself hinged to the shaft? So is the ice cream still on the cone, or is it being pulled away from it? Okay, if it's being pulled away from it, if you've lost your medial hinge, that's again another risk factor for potentially for AVN. Now, in reality, they followed up these patients and looked at the rates of AVN, and it didn't perfectly correlate. But basically, there has been a vascular insult at the time of injury if you've got a small calcar or if the medial hinge is disrupted. That's the take-home message from this. Stun silence. Okay. All right. Yeah. Okay. So this, again, hot off the press, this was an instructional course at BEST this year. This was looking at the rates of AVN in published literature for different segmental fractures. And you can see basically, the more segments you've got, guess what, the more higher the risk of AVN. And it can go up in some series to as high as 90%. Okay, so you've got to start making a judgment as to whether or not you can restore what's in front of you. So when do you operate on these? I'm going to cover the literature in a little while, but the traditional indications for operating on a proximal humeral fracture are comminution, so 3 or more parts. Although I'm sure all of you have seen often 2 parts being operated on as well. Head splits, so in other words, there's an articular fracture and there's displacement of that articular fragment. Displacements, dislocation is almost the strongest indication of all. You've got to operate on them, but none of these are cast in stone. It depends on the patient in front of you. There's patient facts as well. Open, and the reason I write impending is the Edinburgh group also published a series about, in the elderly, impending open fractures. They won't just talk about the upper limb, but often knees. And they're patients who end up with a fracture that you just gradually see emerge out through the skin. And you'll sometimes see that in the humeral shaft. It'll be puckering underneath deltoid, and they'll be sitting on a medical ward, and they won't be wearing a sling, or they'll be in a sling, but then the nursing staff very kindly start piling pillows underneath their arm to give them support, and then a week or so later you see their humerus sticking out. I've seen that 3 times now in 5 years. So it's just a personal thing. But yeah, so just watch out for the impending open fractures and then neurovascular injury. So those are your really strong indications for operating. So treatment options: sling or operate, and I'm going to try and give you some kind of approach to how you think about that. So this was from, again, this is another Robinson paper. So if you want to know anything about upper limb, if you're interested in upper limb, just look his name up. There's loads of stuff. What this does, this slightly complicated chart, I think is pretty much what proximal humeral fractures is all about. It's probably the one slide to take home. Patient factors, fracture personality factors, surgical factors. When do you do non-operative? Well, if it's millimetre space and it's stable, you don't operate on it. Doesn't matter how old they are, doesn't matter how amazing a surgeon you think you are, there's no point in doing an operation. Okay? Well, that's kind of patently obvious, isn't it? That's John Hutchinson has the A, B, and C classification. Have you heard of that? A nobody would operate on it. B, some people would operate on it. C, everybody would operate on it. It's kind of bad, basically. So that's a Hutchinson A, I guess. Relative indications for non-operative treatment. It's all the things you think about. So the patient factors, fracture factors, and then if you're no good at doing the operation, don't try and start learning how to do it. Okay, that makes sense. That's kind of what you get back from the ski field sometimes, isn't it? When they've been away and they're insured, and then they get an operation they really shouldn't have had because they weren't going to escape with a full wallet. And then the relative indications, and they are relative, really, indications for operative treatment. So if you've got someone who is young with a relatively severely displaced fracture, they're going to tolerate your operation, and you're trying to improve their anatomy for the future, trying to give yourself something that even if they get a complication, you've got some kind of better reconstructive option because their anatomy is more normal. And then there's the absolute indications, and these really are rare. There are very few operations. You don't have to operate on most of these patients. So how do we try and sift through all that soup? That's what we're trying to do now. Okay, most of them you're going to manage without an operation. Yeah? Vast majority of them. And that's all the things we've talked about. How long do you keep people in this thing for? I've got 2 weeks. Do I hear 3? 4, 5, 6? How long are people keeping them in this thing? 2? So before PROFA, often people just 6 weeks like this. And then you get them at 6 weeks, and they go, yeah, no, it feels all right. Move your arm. They go, yeah, I can't. What about your elbow? That wasn't injured. No, I can't do that either. So PROFA, 3 weeks in a sling, and that was part of their protocol. Non-operative arm was 3 weeks in a sling, but moving your elbow, wearing the sling outside the clothes, getting it going. I pretty much let them get the arm going as soon as they feel comfortable to do so. I warned them that they're probably going to be sleeping in a chair or with lots of pillows for 4 to 6 weeks, and because they often think that's a bad sign if they're still having to do that, but that's quite common. And they're going to have pain for about 3 months. They may get more function during that time, but for 3 months they're going to feel uncomfortable, it's not going to feel right. That's usually the time period for things to get to the point where it's starting to feel a bit more comfortable. It's quicker for the more simple fractures than it's about that at the time for the more complex. But get them going early, make sure their elbow isn't stiff. And these ones that have the waist strap trussed around themselves, make sure they get rid of that. So make sure the sling's outside the clothes and that they're not getting nappy rash underneath their arms. And yeah, those are the criteria, basically. Simple fractures, not too badly displaced. I'm not going to talk at length about GT fractures. We don't really know which GT fractures we should operate on, but if someone's young, fit, active, and they're displaced by more than 5 mils, then I'll have a chat with them about going on and operating on them. Generally speaking, if it's comminuted, they do worse. They're far more difficult to treat, and they're disappointed with the outcome, and really what you're doing is effectively a cuff repair machine. There's a bone in it. If you've got a large GT fragment that's often you repair it, a simple repair, that actually they tend to do quite well. So the degree of comminution, that isn't something I've read, that's just personal experience, that generally comminuted ones tend to do worse. Okay, so that's non-operative treatment, so get them going early. Hanging U's are out. Okay, they don't really serve a useful purpose, and generally it's just a case of sleep upright and get to physio early. They get better, they've got better outcome, better pain relief. And my personal feeling about it is that if you keep people trussed up for a long time, they often get a capsular restriction, they get a capsulitis that contracts, and then all the subsequent movement they do is through the fracture site, not through the joint. So as soon as you can get some movement, I would encourage them to try and do that to try and prevent the capsulitis element of it. Does that make sense? Am I talking too much shoulder speak? That's either a yes or a no. You can tell me later. Okay. So one of the pros of non-operative. Non-operative management is like a £5 bet on the Grand National. You're not going to win big, but you're not going to lose big either. Okay, so you will do predictably mediocre. That's not really a sentence, is it? You know what I mean? You're going to do predictably average from the non-operative. You might be lucky and do well. You're not going to do really badly. You're not going to have pus pouring out your shoulder. you know, and have in and out of hospital because of multiple admissions and dislocations and stuff. You know, the bandwidth which you oscillate in is going to be relatively narrow, but it's never going to be perfect. They're not going to get back to what they had before for the bad 2 parts, 3 parts, 4 part fractures, but it's low risk. What are the risks of it? Well, they're at high risk potentially of cuff dysfunction and stiffness, high rates of non-union, and if you delay an intervention, so if you do a hemiarthroplasty late, if you try to do a fixation late, their outcome is poorer than if they had early intervention. The problem is we don't know who the people who are going to do badly are. That's what this really all comes down to. That's kind of the challenge of trauma, really, is knowing who your winners are and who the losers who are going to benefit from an intervention. So salvage surgery has poor outcomes. There's a study that I was reading, I can't remember if it was in the recent BJJ, I think it was, oh no, it's in the JSES, that was looking at reverse shoulder arthroplasty to salvage hemiarthroplasties that have gone badly, and they do a lot worse, the dislocation rate's worse. So you want to try and go through a definitive form of operation early, you want to make the decision early, ideally. Okay, so operative. What are the indications? Well, the things we kind of covered, the open, vascular, head split, floating shoulder, etc. And you've got this whole myriad of options. So you've got proximal nails. Has anyone seen any of these proximal humeral fractures managed with a nail? If this was a French audience, you'd all put your hands up, because that's what they use. They tend to use proximal humeral nails. And actually, they are pretty good for the simpler fractures. But there's a caveat, you've got to be using lock screws, you've got to have a constellation of screws that actually grabs the fragments, because otherwise what tends to happen, particularly in elderly bone, it tends to pull out through the carotid head and not actually grab what you want it to grab. Plate fixation, we'll talk about in a second, and then arthroplasty options. So if you're thinking about operative options, the first question is it reconstruct? Is it actually salvageable? Okay, that Ferrari is never going to be the same car if you panel beat it. Okay, effectively, what we do with fracture fixation is we take a mallet to something, we put it back in the right position, and then we hold it there. Yeah. Okay, but that Ferrari, I mean, even the best panel beater in the world, that isn't going to be the same car. All right, and so just remember that. That Calcar element, can you get that Calcar back reduced? Is it an intra or extra capsular fracture? In other words, is there a risk of AVN? Is the head fragment more than a centimetre thick? And what I was trying to show you with the second case there, that 53-year-old guy, he had a wafer-thin articular piece of bone. If I show you the CTs, you see that better. So you can have someone young who you want to go on and fix, but if you've got no bone purchase, well, what are your screws going to fix into? How are you going to fix it? And can you achieve an anatomical reduction? There's a little star there. Can you achieve an anatomical reduction without stripping the hair out of soft tissues? Because every time you take a bit of soft tissue off, you're detaching that cuff that then has to heal. You're severing that bit of blood supply that's still attached to that piece of bone. So the more you do in the shoulder, the heavier your surgical footprint, the higher your AVN rate as well. And also more risk of stiffness and scar tissue formation and adhesions. And that's why this is such a murky pool of whether we should operate and whether we shouldn't. So if you are going to fix these, what are your goals? And this is from the AO website. So you want to be, actually that projects really badly. I'm sorry about that. The bulb's probably about to go here. So what that's showing is a varus neck and a displaced GT, and that you need to correct it and bring it back up. So you want to basically try and get your calcar back aligned and your head, the varus or the valgus of your head correctly aligned. So you want to re-establish your medial hinge, and you want to get your head back in a reasonable position, alignment. And that calcar, it's restoring that calcar buttress to prevent collapse is really important. So that's a technical thing about if you're going to fix these. And when do you salvage? So you should consider arthroplasty really for those really high AVN rates. Now, if you've got a younger patient, you might give them a punt at trying to fix them. But for the older patient, you're going to be going into salvage territory because their rates of AVN, very much the same with the hip. You know, your rates of AVN are going to be unacceptably high. And the things that affect it for me are, what's that calcar fragment like? How much soft tissue stripping have they got? What their age is, what their comorbidities are, etc. And then you've got the question of hemi in reverse, and we don't know the answer to that. So PROPER 2 is looking at, should you be using it, it's randomizing people to hemi or reverse. There is a suggestion from case series at the moment that reverses may be better as a primary intervention of the elderly than hemis. Because the problem with the hemi is, you put the hemi in, and if the tuberosities don't resolve, and if the cuff is still functional, then they do quite well for the 5 or 6 years that they don't grow their gleamers. But they do quite well for that period of time. But it's really unpredictable as to whether or not the tuberosities resolve. If the tuberosities resolve, it all goes to guano, basically. And the head starts riding up, and they start getting pain. Whereas with a reverse shoulder replacement, you put that in, you don't need to worry about the cuff. You don't really need to worry so much about the tuberosities. You just need to get the implant in. They don't do as well as for elective surgery, so it's very similar kind of population group to the total hips for trauma. But there's some evidence that they probably do better. So PROPER 2 hopefully will give us that answer. Has anyone got any questions about that?
Did you ever put hemis in there?
Yes.
And when would you choose that? Just for
so I was going to cover it on the slide, but I may as well cover it now. So if I've got someone in front of me who's got an unsalvageable head and they're fracture dislocated out the back and I think they need an operation and they're fit enough to have an operation, if they were a hemiarthroplasty type hip patient, I put in a hemi. Because I'm not trying to give them a good functioning shoulder, I'm trying to give them a shoulder that sits in joints. I'm not trying to give them the shoulder they had before, they're never going to get that yet. If I've got someone in front of me who is independent, AMT 10, and would be a total hip candidate, I put in the reverse. That's based on nothing. There's no evidence behind that. I was a really slow adopter of reverses. And the reason I was a slow adopter was because you've got a patient group that declared themselves as osteoporotic and fallers, and they're going to fall again. And I'm putting my salvage operation into their shoulder, which they can then fracture again, or dislocate, or do something bad to. But I've now rationalised that I had such unpredictable results with hemi. When they did well, they did really well. When they did poorly, they did really badly. And we know that salvaging a hemi to a reverse is awful. But now, in the higher functioning elderly, I now put reverses. Does that make sense? So if I put a total in, I'll put a reverse in. The younger people, I'm still not sure. I don't know. I generally tend to try and fix them. I have a far higher threshold before I think about arthroplasty. Okay, so you guys got PROPER. I don't know how many of you worked your way through it. So what was the issue about PROPER? PROPER was a pragmatic study. Again, Bristol was one of the centres that took part here. So what they said is that if you've got a patient you think might need an operation, and they've got a displaced 2 or 3 or 4 part fracture, they're eligible for being recruited into PROPER. You could exclude people who you thought definitely needed an operation and people who you thought definitely didn't need an operation. It turned out, nationally, there was massive difference in what people thought definitely needed an operation and what didn't. So what you did is you got a whole bunch of fractures and you said, the group who we're not sure whether they benefit from an operation among shoulder specialists, you can recruit them into a study and see if it's one thing's better than another. And guess what? You had a group of patients who were in equipoise, and we found equipoise. So that's kind of one of the problems with PROPER. And Mike McKee, again, that kind of Canadian bloke, did for the JBJ, I think it's published in the JBJS, America. And they often do this kind of little podcast narrative or critique of the paper. They get an expert to critique it, and he critiqued it. And he came up with a number of things. Now, this was from this year's best, talk about limitations of PROPER. The real thing was that there were too many exclusions. So if you looked at those who were deemed ineligible, and there were over 600 of them, they had very similar characteristics to the eligible. In other words, there was disagreement among the people recruiting about who definitely needed and who definitely didn't need interventions. And so it turned out that the people in the study were quite similar to some of the people who were excluded. You with me so far? Yeah. Those who didn't give their consent, who were non-consenting, also had pretty similar characteristics. So what does that tell us? So we think that there was a degree of pressure from people recruiting, saying, look, you're potentially eligible, but my feeling is you'd probably benefit from an operation, or you're potentially eligible, but actually I think you'd be better served by. So we think there was a degree of recruitment bias potentially in there. And treatment preference was generally towards non-surgical. In other words, people who recruiters thought probably would benefit from not having an operation were reluctant to recruit into a study where they'd end up doing an operation on them. Does that make sense? So the pragmatic nature of the study kind of, in many ways, undermined it. And reverse wasn't in the treatment arm as well. It wasn't specifically looked at. That said, PROFA has proved really useful. In my hands, PROFA has proved really useful. So if I've got a patient where I'm not convinced that they need something doing, and we still don't really know who we definitely need to operate on, I say to them that evidence doesn't currently support operating on you.
That's why everyone likes it, isn't it? 'Cause it's,
Yeah, so it gives us an opt-out. Okay, so how do you incorporate that into consent? And I'll come on to that, actually. I'll come on to how you can consider that. So what are the complications? There are complications relating specifically to the injury, but there are also complications pertaining to the patient. And there's a whole bunch, a list of them, basically, okay, when you intervene. So I'm not going to go through those in detail, but basically what this all comes down to is you're kind of, when you're choosing whether or not you're going to intervene or you're not going to intervene, you're choosing, very much like we talked about earlier, which constellation of risks and problems you want to have. Okay, and we don't yet know the answer. So PROFA 2 is looking at 3 and 4 part fractures, including fracture dislocations, and randomising them to either reverse hemi and a fifth of them to non-operative, if they're able to get a close reduction in the circumstance of a fracture dislocation. So what I tell patients is they can choose which cup of poison they want. Okay, so they can do. The patients will often say to you, "What would you do, doctor?" And I try and give them a politician's answer on this one. It really comes according to your appreciation of risk. I don't know how many of you have sat down with a financial advisor and they get you to do all these questions. And they categorise you as someone who's a low risk person, or likes to take moderate risk, or somebody who likes to take high risk. Okay, I think it's the same situation with this. And actually, that's a very personal thing. So my opinion about it is irrelevant. If I thought they needed an operation, I'd push them towards that. But when you've got equipoise, when you've got a situation where the evidence doesn't support it, the way I put it to them is this: you're going to do predictably poor or predictably average if we do nothing, but the risks are pretty slim. So it's like a 5 quid sweepstake. Okay? But if you fancy yourself as a bit of a high roller, if you want to put £2,000 down on a bet, you can win big, but you can lose big too. Okay, so you're giving them a far broader bandwidth of potential complications. Does that kind of make sense? So that's what I think PROFA has given us, is the ability to discuss the equipoise a little bit more with them. We're still trying to clarify who to operate on. Has anyone got any questions about that? Because there's a question at the break about.
Just very quickly, the fact that you mentioned about reverses, has that now completely changed the sort of the profile? Because this study is now essentially out of date, even as it was years ago. And now because you've got reverses, and that's sort of new technology, it's been here for a while, that the impact of PROFA doesn't kind of.
Well, we haven't yet got evidence to support it. The indications reverses will probably be better, but we don't have the evidence base for it. So I don't think it's out of date yet. PROFA 2 should make it out of date if it gives us an answer. We're supposing, when we started fixing risks, we thought Vova locking plates were going to be like way forward. This may be the emperor's new clothes with reverses. You just give yourself a different complication profile. You start having periprosthetic fractures, you start having premature loosening. There's evidence that bisphosphonates, that preoperative bisphosphonates, or people who are on bisphosphonates already, has a deleterious effect to shoulder arthroplasty. So this is a population group who are many of them are on bisphosphonates. Are we going to start getting bitten by that? I don't know. So the answer is we don't know. So what's my preference? I like X-rays and I like proper X-rays, so I get that grey sheet view. Okay, so as soon as they're into my clinic, they get a grey sheet view when I'm in for the first time. I only use CT if I'm considering reconstruction. Early review. I want to get this person as soon as possible. Trying to fix someone's proximal humerus 3, 4, 5 weeks down the line is misery. Trying to fix it day 1 or 2 or week 1 is a lot easier. So I try and get hold of patients as quickly as possible. And I try and make a decision about them early. So either we're going to operate on them, we make that decision, or we're not going to operate on them, in which case I'm going to see them in 8 weeks or whatever. I try and differentiate early on. Collar and cuff, if they're not going to have an operation, and key is early mobilisation, and I try and operate on them within 2 weeks. Does that make sense? little bit so that's for the surgical candidates. I've talked to you about TSR versus Hemi and my thoughts. So that's an example of when you've got a Hemi that's basically the tuberosities originally were on, it was in the right place, and then it just starts superiorly migrating. The tuberosities to zone 22. So operative steps, approaches. What approaches have you guys seen for these? You've got choice between delta pectoral, Jude, Mackenzie. Most people doing delta pec.
Yeah.
Has anyone seen any Mackenzies? Yeah, who was doing those?
The Stringelica for the trauma ones.
For the arthroplasty or the fixation or
For
both?
reverse. For the surgery arthroplasty.
Oh, really? Okay.
Reverse, yeah.
Yeah. Okay, my colleague David Woods does some Mackenzies for these. Yeah. James?
Wolfhouse. That was there.
Yeah.
Surgeon.
For plating?
No, for the arthroplasty.
For the arthroplasty. What about the fixation? Mike Kelly here for a time was using Mackenzies. Robinson in Edinburgh tends to use a brass strap incision and then split, go through transdeltoid approach, Mackenzie approach. The problem is that when you're trying to put all your screws in, you tend to be hitting the axillary nerve through the deltoid. So I've tried it. I use it for posterior dislocations. When you screw, it's really difficult to get around the back. So for most of them, I tend to go delta pec, but I will go transdeltoid for ones where the business is all around the back and I'm trying to get all that stuff back around. Plating through a Mackenzie is actually quite a lot easier. So you have to think about your approach. Two options, delta pec. I mean, that's the workhorse. The reason why most shoulder surgeons like it is because it doesn't have such a high risk of the axillary nerve, which may have already been clobbered by the injury. And salvage options, you can extend the incision all the way down. So if you end up doing further operations down the line for taking a plate out for their ABN, etc., it's just an easier approach to work through than a Mackenzie when everything's scarred down including the nerve. But Mackenzie or anterolateral transdeltoid, whatever you want to call it, is an option. And one you should be aware of. They're going to need to replace the bulb, aren't they? It's projecting really badly. I'm sorry about that. The problem with the deltoid splitting is it's got a slightly higher axillary nerve injury rate, but actually, for seeing GT and the lesser tuberosity, it actually makes it quite easy. You get, because otherwise, with the delta pec, you're constantly working around the deltoid. So, what are the steps? I don't know if this is a bit too much detail for you guys actually, but in core principles, first thing you do is get in there, obviously, identify the fragments, and that can be quite tricky when you're not used to the anatomy. And you put stay stitches into the lesser tuberosity and the greater tuberosity, and that starts to give you control, and you can start to pull on those as needed to get your reduction. You then reduce the head onto the shaft, and Parker Sarangi always says, "Thou shalt not commit varus." Okay, so you don't want to have the head going into varus because it can end up slipping down and off. It's one of the risk factors for displacement. Once you've got the head back into alignment, and there's a number of tips and tricks, you then pull the tuberosities round. And one thing you can do is even tie those tuberosity stays at that stage and give yourself effectively a two-part fracture that you then plate. And then finally you apply the plate in a position where it's going to avoid impingement. And that's pretty much how to fix proximal humeral fracture. Those are the sequences and the steps that you can do. A couple of things. AVN's a risk. You're worried about AVN head collapse. If you go through with your drill, you probably shouldn't be putting a lock screw in that, or you should be putting a peg instead, or maybe an unlock screw. That's the general advice, because if the collapse happens, that's the one screw that will go straight through and penetrate and start wearing away the glenoid. You want to go long with your bottom screws. They're what's supporting the head. It's called the kickstand screw. So you're familiar with that in the tibial plateau? The screw that goes all the way across and supports from I think it's usually the lateral side, and then all the way across the medial plateau. So the kickstand in this is the Calcar screw, and it should be long, so that it's going to support the articular head, so that the articular fragment doesn't fall off. And you want to go slightly shorter with your top screws, because those are the ones that, as it collapses, are likely to cause you problems with the AVN. Yeah, okay. Okay. We've got the final 10 minutes, we'll have time for humours. So, who wants to have a go at this? 15-year-old girl, left hand dominant. Who's the niece of one of your senior colleagues in the job that you've just taken in the District General Hospital that you work in? So she's fallen over. She's from another part of the country. They've told her to wear a sling. You're showing these x-rays. He's going to have to edit. That's okay. James, you want to go next?
I can't really determine much from the lateral or the scaffold work.
They're crap x-rays, aren't they?
Yeah.
Can you tell what you need to about this? So what are your options? Maybe it's more information.
Clinically review the patient, get some more x-rays.
Yeah, it gets more x-rays. Yeah. Radiology department say you've got that's the best imaging you can get, she's A.
CT.
Yeah, use CT, she's 15. You could get CT, I haven't got CT. So I thought this was probably a lot worse than let's see if we can do the match of the day thing again. So I couldn't tell what was happening here. See the shaft there? You come up there, you can see the tip of the shaft is there, and yet the head is all the way down at the bottom. So there's quite a discrepancy. So I thought I thought it was going to be really angulated. And the reason I bring this up is because this is someone who's not skeletally mature. Physis is probably still open here. Most of your growth, 80% of your growth happens in the proximal humerus, 20% in the distal. So the capacity for remodeling is high, but she was 15. So I started having to ask questions like, well, okay, it's also taking scaling history. You know, is this someone who has got more growth capacity? Is she 2 years post-menses, etc., etc.? How much capacity has this girl got to carry on growing? And on the basis of what she told me, I didn't think she did have much capacity. And I thought she was going to have displacement, and I didn't know what the answer was. So traditionally in kids, you can accept quite a lot of displacement because they'll remodel it. But she's at that tail end of adolescence, and I wasn't sure. So I took a theatre and said I'd screen it and make a decision in theatre. And that's what I found. Okay, so what would you do with that? I love it. Okay. How are you going to fix it?
Using this age group, depends on reductions. Because if for example, if this was produced, say pre-screen, you wouldn't necessarily fix it for the
Yeah, you can't see it on here, but she has got a kind of calcar fragment there. That was one of the things I was looking at, see how she had a reasonable sized calcar fragment. So I thought the vascularity was all right. But to be fair, you didn't put anyway, aren't you? I mean, 15, you're not doing basement. Okay, I want you to vote now. Okay, who's going to plate it? Who's going to nail it? Okay, John's going to nail it. That's reasonable because I can't remember. I think I'll come to it, but so nails have got a higher rate of shoulder pain than plates, so I tend to use them preferentially in the elderly, and also this is a two-part fracture. Who would wire it?
That's an option. You can reduce
So
it.
in France, you'd wire it. They tend to use these elastic nails and things. So a number of times I've seen people come back with these wires, and you think, what the hell are they having done? But the reason I wired her was because actually I thought she's still got capacity for growth. This is a paediatric injury, although she's adolescent, you know, so she's tail end of childhood. And I thought I could probably get away with it. And so I just did a mini open approach here, put something in, got the reduction, was happy with the screen, and then put the wires in. And actually, definitively, that ended up working for her. And then we took I left the wires out and took them out. It was good. So the reason I mention that is paediatric proximal humeral fracture is just a little bit different. And there are parts of the world where definitively they'll manage this with wiring. So it was just a complete circuit there. Anyway, it worked in her, thank goodness. And my senior colleague was happy. Right, why don't we make this the last case? Okay, who wants to go at this one? So 49, otherwise fitting well. These are the X-ray views you've got. Move on to the CTs. So the CTs you saw earlier. So I want you to have a think about what you can see on these images. Make a value judgment on what you think about the vascularity. Is it intra, is it extracapsular? On the basis of profile, does this definitely need an operation?
Only 4 parts in profile.
So
Not many 4 parts in profile.
there are not many 4 parts in profile. So that was the point, is that basically some of the high grade things, high grade fractures, people said definitely need an operation, therefore excluded. So that's where the kind of pragmatic element that came away. Okay. This lady says to you, 49, I'm fit and active, I've got no other medical problems. I'm not sure if I want an operation. Is anyone going to try and persuade her to have an operation? Everyone's shaking their heads. So that's quite different. There will definitely be meetings you'll go to where people say this person has to have an operation. They're usually not UK surgeons, but particularly Australian or American surgeons where you can't escape without having an operation. Okay, so she said, I've heard the risks and I'd like to have an operation. I'm keen to have something done. This isn't right. I'm not happy that I'm going to do well. It's not going to be the same shoulder. I want the best shot at getting this better. Who's going to plate it? Anyone going to nail it? No, no nails. Anyone going to replace it? Okay, and what are going to be your principles of fixing it? Grab the tuberosities. Yeah, does Pep or anyone doing Mackenzie? No, we've been beaten sufficient. Okay, so so that was actually the example of those are the pictures that you saw. So yeah, she went ahead for fixation. I think that is.
What would you have said to her? Sorry.
No.
What would you have said to her if she, in that I don't want an operation conversation? Because you have to give her a sort of balanced view of how you think her outcomes are because not everything. And there's a significant body of people who would think she'd do very badly from that, particularly with that GT up that's impinged.
So what I say to them is, we don't know what the right answer is for this. My feeling is I can anatomically make your shoulder look better than it currently is. I'm seeing you relatively early. The indicators from your X-ray are that you actually, and from your CTs, are that your risk of avascular necrosis should be in the lower risk group, given that you've got 4 pieces to this break. And if you go on to develop a problem and have a malunion, I can probably deal with it more easily if I can get everything back into a normal shape than if I have to deal with the sequelae of this further down the line. But that said, I can't guarantee you that you're not going to have a complication, and I can make your life a lot worse. I give them the betting analogy. So I say, look, you've got more to lose by me doing an operation, but I'm also giving you a chance of having a better functioning shoulder than I think you potentially would have if I left it alone. And that's how I posit it to them. And then, yeah.
And in terms of the function, is it that GT fragment that's going to impinge that's going to cause the problem? Or?
So we don't really know. So so there are bony elements to it. So there's the valgus, there's the GT high riding, which can cause impingement. You can always do a decompression later for that, potentially. But the other problem is you've got hematoma and you've got deltoid adherent to that area, and you've also got a slightly dysfunctional cuff, and you don't know what cuff damage has happened. And that's where the variables of why we don't know whether it's going to help them or not happen. If she develops a non-union, she'll be worse off. But she's a valgus impacted, so that's relatively low risk. And a hinge is kind of incarcerated, but it's still kind of there. And the other risk is that she just gets instability, that she gets a worsening position. You'll sometimes see in the elderly when you manage them neurologically, the position actually almost seems to get better over time, weirdly. So, yeah, I would tell her what the potential risks are, but I can't quantify it. I don't think anyone can. But I don't try and persuade anyone to have an operation. And what I normally do is send them off for a coffee. So I see them, and I say, look, just go away, discuss it, and then come back towards the end of the clinic and we can have another chat about it. You can do a bit of research if you want to, have a little shoulder dog kind of thing. What was that? Final X-ray. So, this is playing me up. So I'll just go back to this last one. This is a guy from last week, actually. Had a week of weird and wonderful stuff. So this 45-year-old chap. So basically, he's 45. He'd had a temporary crown put on his tooth, so there wasn't any active infection, but his crown was quite sore. And to soothe it, he drank a lot of water. I mean, a lot of water. Okay, so when he came in, he'd fitted. He had an unwitness fit. He was hyponatremic at 115, and he'd had 10 litres, I think, of water in the previous 24 hours. Now, the other time you sometimes see this is with ecstasy, people drinking too much when they've popped a tab. So he was taken to theatre by the on-call team. They popped his shoulder back in, but it was inherently unstable. So we got these 3D recons. So his renal is okay, and he's posteriorly dislocated. That's the anterior part of his humeral head. So when we talk about epileptic seizures, 50-50 chance of going front or back. So he had a posterior dislocation. Who wants to have a go at this? What to do with this? He says, it doesn't feel right. As soon as he's been placed in, he's got a pillow around his arms. They put him in external rotation split. It's probably one of the few indications for one. Like this. So he's got this pillow and he's got this polysling. And he goes, as soon as I try and bring my arm in or anything like that, it doesn't feel right.
So the seizures before?
No.
So it's a bit flat on the
Yeah, no, he did that in one fit. Oh, he works as an accountant. Oh, thank God. And he went, yeah, but I'm just about to hand my notes in because I want to become a personal trainer. And he's quite big. He's a 45-year-old, but he looks like he's found the gym. Denies anabolic steroid use. I asked him about that. And my first thing was, you're mad because you've drunk 10 litres of fluid. Are you sure you're not taking drugs? You know, part of the body beautiful, pepped up, snorting coke, that kind of, fast lifestyle. But it turned out he wasn't, he said. So we got the neurologist. So the key with this is you've got to sort out fits. You can't operate on someone who's actively fitting, all right? So the question is, has he had a precipitated seizure, or is this a new onset of epilepsy? And he had hyponatremia. The neurologists were absolutely convinced it was polydipsy-related seizures. He didn't even need an anti-epileptic. We brought his sodium back up and he was stable. He was felt to be as good as he was going to get. Got a head CT, it was normal. They didn't MRI. So we got as much of a green light as you're able to get for this guy. What are the options? What would you do this?
Well, it's pretty niche, isn't it? Because it's not even like locked posterior dislocation with a massive reversal sacs that you do in McLaughlin for, put a hemicap on because he's got half of his articular surface sat in the middle of that.
Yeah, the Jets actually took him to theatre and managed to get him back without fracturing it, which I think was a small miracle.
So obviously I haven't got a clue, but so I think the traditional hemicap and McLaughlin aren't really going to give him the shoulder that he wants, and you probably want
so
to do.
options are, so what Pete's talking about with a hemicap, you put a little disc. So this is an orange shaped hole, but you put a little disc with a little kind of HA coated kind of almost like a screw or a friction fit peg that you push into it. You basically push into the hole, so you can do that hemicap. McLaughlin is when you put your subscap, you move subscap and put it into the defect so that they can't, when they rotate in, they hit subscap instead.
And then you start thinking about some sort of made-up operation where you like put the articular surface back and try and stabilise it there. But how would you stabilise it there? So I don't know.
Shoulders post-exam. Anything you do? Yeah, that sounds really American, doesn't it? Yeah, I'm going to put a dead person in your shoulder. You're 45, and I'm going to get. So, and we've screened them for HIV and for hepatitis. We're not so sure about prions, but they're old, so they probably have prions. I'm going to put a piece of dead tissue in your shoulder. Yeah, so that's what I did. I didn't know what else to do. It was a one time. I'm not a huge fan of using dead bits of people in there. And then next question would be the approach. So I took off subscat and basically levered the fragment out and then elevated all the chondral surface, and then got a piece of foil from the suture packet and templated it, and then put it on a piece of femoral head. And we had a femoral head bone bag, and then basically cut a segment out that matched it, and then put it in, and then fixed it with 2 heads compression screws, having flipped the piece I'd taken out back over the top of it, and it seemed to work. Now this guy's now 2 weeks down the line, so I don't know what we're going to be confronted with, but it was stable afterwards. So I put that in there as just an aside thing, because I don't know what the right answer is, guys, but so far he's all right.
Is that femoral head with some sort of hyaline cartilage?
So what I did was I elevated the impacted chondral surface up and then put the femoral head underneath it,
Oh, right.
and left a small chondral defect which was irreparable. And then
And those screws are sort of like raft
they're
screws,
front
kind
to
of.
back.
Yeah.
So they're through the lesser tuberosity and articular surface that I flipped out the way, and then through the graft and then into the head.
So you've made up an operation.
I made up an operation. I'm going to leave it at that because I think it's now 20 to 5. I'm sorry we didn't cover humeruses, but it was quite a big topic, and I just thought it was better to cover these things. I think that the money here is in clavicles and in proximal humeruses, and having some idea of the decision-making processes. Hopefully I haven't confused you more. Has anyone got any burning questions or anything that they want to ask this week? Okay, right. Well, then that's